little growths, or rather condensation of the muscles of the wall of the uterus. Almost 40 to 50% of women have fibroids. Some studies say that up to 70% of women may have fibroids. Fortunately, 90% of fibroids are asymptomatic, which means they do not cause any symptoms. Most of them are incidentally picked up nowadays because we do ultrasound scans for all sorts of reasons and often for no reasons. Fibroids, for all practical purposes, are benign. They become cancerous only extremely rarely. Fibroids are growths that are dependent on the hormone estrogen, and therefore they thrive while a woman has estrogen in the system, and they always start shrinking after menopause once there is less estrogen in the body. The peak age of incidence of fibroids causing symptoms and therefore needing medical attention is around 30 to 40 years of age. Fibroids always, as I said, grows from the muscles of the wall of the womb. When they are completely within the wall of the womb, they are called intramural fibroids. However, when they grow, they may grow outwards towards the outer surface of the womb and push outwards. They are then called subserosal fibroid, serosa being the outer surface of the wall of the womb. Very rarely, they may push out of the wall of the womb so much so as to be completely extruded out of the wall and develop a little pedicle through which it is attached to the wall of the womb. These are called pedunculated fibroids. Occasionally, fibroids may grow inwards into the cavity of the womb from the muscle from where it grows. When it grows into the cavity of the womb, it distorts the cavity of the womb, and these are called submucous fibroids. Quite often, with regards to bleeding problem that fibroids cause or fertility problems that fibroids may occasionally be associated with, these fibroids that are protruding inside the cavity of the womb, the submucous component, they may cause implantation problems and may increase the risk of miscarriages and also in pregnancy malpresentation, which means the baby may not be in the right position with head down before delivery. Fibroids that are not pushing into the cavity, it's a little ambiguous evidence-wise as to whether and how much they affect fertility. They may cause malpresentation, as I said. The general consensus at the moment is that if there are no other causes of fertility issues found and a fibroid is more than 5 centimeters and not pushing into the cavity, or it's in a location that may affect fertility, like close to the tubes, then it may be wise to remove the fibroids, namely a myomectomy. Fibroids that are pushing into the cavity definitely needs to be removed from a fertility perspective. With regards to investigations, the fibroids on examination may be easily palpable abdominally, we can feel it. But on investigation, an ultrasound scan, both an tummy scan, an abdominal ultrasound, as well as a vaginal or an internal ultrasound are needed to check fibroids. Occasionally, if the fibroid particularly is intracavity, so inside the cavity of the womb, one may sometimes benefit from pushing in a little fluid called a saline infusion sonography to delineate the fibroid better. MRI is sometimes needed if there are multiple fibroids to do what we call a fibroid mapping, generally preoperatively, to have a good idea about the fibroids. Very rarely one may need a hysteroscopy, which is a little telescope put without anesthetic or under local anesthetic, or very rarely under general anesthetic, to have a look inside the womb to see the fibroids that are pushing inside the cavity. Once we find a fibroid, the treatment for a fibroid mostly depends on the symptoms it is causing. As I said before, if menstrual problem is the main issue, heavy or irregular menstrual bleeding, then temporarily, unless the fibroid is in the cavity, one can just take symptomatic control, have symptomatic control with mefenamic acid or tranexamic acid. Particularly if the bleeding is very regular, then mefenamic and tranexamic acid often is enough. If the bleeding is irregular or mefenamic and tranexamic acid is not good enough, then a combined contraceptive pill may help, or progesterone tablets in the long term. If the cavity is smooth and the uterus is not very big because of the fibroids, then a Mirena intrauterine coil or a levonorgestrel containing coil can be very effective. These are mainly for control of bleeding. If that does not help, then quite often the fibroid needs removal. If the fibroid is within the cavity entirely or mostly, then mostly we can remove the fibroid through what's called a hysteroscopic resection of the fibroid, which is inserting a telescope through the vagina, through the cervix, into the womb, and resecting or removing the fibroid. So hysteroscopic resection for fibroids that are inside the cavity. If there are one or two fibroids that are outside the uterus, on the outer surface of the uterus, or inside the muscles of the uterus, they can be usually removed through laparoscopic resection, through keyhole, through the tummy, or a combination of procedures may be used. However, if there are very large fibroids, and in particular if there are multiple fibroids, then of course they may have to have an open surgery, which is through a small cut down below, like a cesarean section scar, or very rarely an up and down scar if the fibroid is very big. Sometimes, particularly if there are big fibroids and multiple fibroids, one may need to have an injection, generally a monthly injection, or sometimes a 3-monthly injection, usually for about 3 months, called a GnRH analog, which is a gonadotrophin releasing hormone analog that induces a menopause-like state, temporarily shuts down the hormonal system and helps starving the fibroids of oxygen, so that the fibroids hopefully shrink and their blood supply decreases, potentially making surgery slightly easier, or and a laparoscopic or hysteroscopic surgery possible. GnRH analog cannot be given in the long term, generally not more than 6 months at a time, mainly because of a risk of osteoporosis or bone loss in the long term if used. There are other treatment options available called uterine artery embolization, which is generally done by the interventional radiologists in the X-ray department, where a little catheter is passed under X-ray guidance through generally a blood vessel in the upper thigh, and is directed into the main blood vessel of the uterus of the womb, and little pellets are used to block the main blood supply. The uterus still gets blood from other sources, but overall blood supply having diminished, the fibroids generally shrink. Apart from this, there is a drug that may sometimes be used to help shrink fibroids. These are called progesterone receptor modulators. However, because of potential side effects, there has been some concerns in their long-term use, and at the moment they are somewhat restricted, or one is normally quite cautious about their uses. So in summary, fibroids are very common. They are more common in Black women than in Caucasian women. They are generally asymptomatic, do not cause problems, and very rarely, if any, cause cancer. They are dependent on the hormone estrogen and therefore almost always shrink after menopause. They normally do not cause problems, but as I said, the common problems they may cause is heavy or irregular menstrual bleeding, pressure symptoms by virtue of their size, and sometimes fertility issues. Symptoms can be treated with medicines, particularly when it's heavy bleeding, or with a Mirena coil. Sometimes, however, surgery may be needed if they're very big and cause discomfort or pressure symptoms or fertility issues or bleeding. Surgery can be done through hysteroscopically, through a telescope through the cervix, or laparoscopically, or myomectomy as an open procedure. However, once the family is complete, hysterectomy generally is the more definitive surgery to remove the womb, which again, depending on the size of the fibroids, may be done either laparoscopically or through an open surgery. Thank you.